Welcome to Good Sex at NYU, a podcast about sex, relationships, health, and mental health, in a sex-positive space. So if you're looking for something serious, sometimes funny, and always sex-positive, then you're in the right place. I'm Danielle Elliman. I use she/her pronouns, and I'm the Associate Director of Sexual and Relationship Respect Services. This is Good Sex at NYU, your space for sex-positive conversations about relationships, sex, and well-being. Thanks for joining us. Welcome to Good Sex at NYU. I'm Danielle Elliman, and I am here with my co-host, Sage Latella. We're joined today by Dr. Sandra Corrett Rivera, and she is a podcast regular. You've now been on 2 of our podcasts. Season 2, you were on episode 10. We talked about pap smears and HPV. And then also in season 2, we talked about dysmenorrhea, which I learned how to say, but also learned that it means pain during sex. And that was on episode 19. So hopefully folks will check out those episodes as well. But today we're here to talk about something a little bit different, but in the same vein.
Yeah, so we are definitely happy to have you, Dr. Corrett Rivera, to talk about pain during menstruation, or also called dysmenorrhea. Now, Dr. Corrett has been an OB/GYN for over 30 years, practicing in various environments from family to private practice, as well as community clinics. She has been at NYU Student Health Center for over 4 years and has a lot of expertise to share with us. So my first question, most people likely know that like the basics of menstruation, but just to kind of reiterate, can you share what happens in the body during menstruation?
Of course. First of all, thank you for having me again, Danielle and Sage. It's very nice and welcoming to be here, and very excited for this topic. So the menstrual cycle, as we know, is going to be something that is hormonal controlled. That's the word, controlled. So as we are going in through the menarche or the first stages of development, we start producing some hormones, and these are estrogen, and the estrogen will be developing certain characteristics, and then gets to a point that then there is another stage where you're going to then start ovulating or producing or liberating eggs, and that's going to be led by another hormone, which is LH, or luteinizing hormone. And then after that, if the following part of the cycle is led by progesterone. So it's those 3 hormones that are really regulating your menstrual cycle. The first cycle, the follicular part, is where everything is growing. The endometrium, or the lining of the uterus, the womb, is getting ready for probably a pregnancy, because that's the purpose of having ovulation and then, menstruation if you don't have pregnancy there. So the first part of the cycle is the one that it varies. So you can have a cycle for most people, maybe 28 days in length, but some people have 35 days in between. And that is still within the norm. And that first part of the cycle is the one that gets to control the length of the cycle. So then you ovulate, everybody does that will ovulate, and then 14 days after ovulation is when you have the menstrual period, and if there is no pregnancy. So that is kind of like a fixed part of the menstrual cycle. Okay? So it depends, where you are, but usually you will have your first period around 12 and a half years of age, and depending on, if you have it or not, 14 years, 15 years, there are some already concerns there if there's no development, okay? The cycle usually, as I mentioned, is anywhere from 21 to 35 days. As you mature, it tends to be more regular. 28 days is the average, but that's not set in stone. And at the beginning, it could be anywhere from 2 to 3 years for all that cycling once you first start, to become more steady, more regular. Okay? So if you have your period one day and then 3 months pass and you did not have it, it's not abnormal. Once you pass those first 2 or 3 years, then yes, you cannot or should not be having every 2 or 3 months menstrual periods. They should be more frequent than that. Okay? And that's, of course, another topic.
Yeah.
And usually the length of the menstrual cycle per se, the bleeding part, is anywhere from 3 to 7 days. That's kind of like an average. And then most people, do use some form of product, either a sanitary napkin or a tampon, or even the menstrual cup. And then if you're using the pads or the tampons, maybe 2-3 changes a day, up to 5 changes a day, that is an acceptable amount of blood to be lost. Okay. So that's kind of like in a nutshell what happens during the menstrual cycle. So is estrogen comes in, produces the lining to be proliferative, to start developing. You ovulate, and then the proliferation comes into prepare for a pregnancy. There is no pregnancy, all sheds out, and that's the period.
Yeah.
So that's a cyclic on and on and on.
Yeah. I think that's really helpful to know. I sometimes forget and just think that menstrual cycle is just that time of the month. It's just the period. And I think a lot of people just kind of associate it with like when blood arrives. And so I think it's really helpful to remember it's not just happening that specific time. There's other things that are happening within the body. So I really appreciate you like sharing. Again, I know it's basic, but I think it's also really helpful.
No, and because of the hormones that are playing part into it, obviously they have effects in other parts of your body. So you have other symptoms, you have other things that are associated with the hormonal changes, which is a natural change. So it's not a steady thing. So do say, or most people come in and say, oh, I have a hormonal imbalance. Of course you do.
Yeah.
Because it is not just one day, every single day, the same amount. It goes fluctuation from the time of the day and from the time of the cycle that you are. And there are many things that will affect that. Yeah. And it's all correlated with stress, insomnia, cortisol levels. I mean, we can talk about this forever. So let's just move on to the next question.
Yeah. I was having some reactions because I remember, some of those days when like all different kinds of, hormonal things that were happening for me.
Feelings, yeah.
Yes, definitely.
Mood changes. I mean, you name it.
Yeah. But I think like one of the things that I associate most with my menstrual cycle is pain. I had really terrible pain when I was younger. I would stay home and not be able to go to school. So it was really rough for me. And so I'm thinking about when I was that age, it was like, oh, just like be tough it out. Like, it's not that bad. So there's this, I think sometimes a stigma connected to like what is normal and what we can like all endure. Right. And I think that that's hopefully something that's been shifting since I was that age, since I was like so young. But I think like, to just power through it is something that hopefully we've gotten around. But when you think about like, when is an appropriate time to seek medical support when you are experiencing pain? Because again, I think there's so much out there that, TikToks and influencers trying to tell you things. So I'm wondering if you can help us like figure that out.
Okay. So first, let's say that at any time that you are concerned, you should seek attention of a professional. So sure, social media helps out a lot today. In a lot of venues are very well documented and have information that is accurate, but there are others that are not so much. So you have to be very careful when you use that media or form of to gather information. So I don't say, well, if your pain goes away with taking an ibuprofen, for just say a brand name or a product, it doesn't mean that you don't have to go to the doctor to make sure, or to your professional provider, healthcare provider, to see, is that normal? Because everybody has a different perception of what, or tolerance of what the pain is. Okay, so this is very important. Not everybody perceives the same amount of pain the same way.
Yeah.
So there is, again, I cannot tell you, wait until this happens to go to the provider. I just say, whenever you think that you need to see the provider, just go for it.
Yeah.
That's what we're here for.
Yeah. And I think one of the things to just add into that is like your pain is real.
It is real.
Right. And I think that sometimes we get into this mentality that others are putting up with it, so we should have to just put up with it. Or we go in and we might have had some bad experiences with doctors that say, oh, like, I'm sorry, like, you're probably just imagining it, or, oh, it's not so bad, like, you're going to be fine, you're just adjusting. And so, like, your pain is real, and so you should, definitely seek a provider whenever you're worried or concerned about anything, but also like when the pain is there, it's okay to go and talk to someone about it.
Yeah, I mean, there is unfortunately a lot of that because there are indeed not everybody so empathetic, or sympathetic as either, to somebody else's concerns. So unfortunately, yeah, that happens in the medical profession. And also there is a lot of, I would say, cultural influences that sometimes in even family members and or religious beliefs will say you have to endure that. Or I mean, I'm not criticizing anybody. I'm just like saying these are just part of the culture that is out there. And if it's now your opportunity to seek outside of that and it's allowed for you to do that, then why not do so?
Yeah. And this is kind of off topic, but kind of the same. Have you all seen some of these like TikTok videos where there's some kind of machine that will replicate the experience of menstrual pain, and people of different identities like try to withstand certain amount of pain? I find that just really, like, first of all, humorous, but also interesting to see other people, like, is that really replicating it? But also, again, I think it's just for my like sense of humor.
Yeah, no, I mean, I have to admit, no, I have not seen that. I'm not reading social media, so.
That's fair. Yeah.
But I think I've heard about that. And indeed, there are scientifically and in our trainings that we do have stimulators to simulate certain type of stages of pain and other kinds of medical conditions. So it will not be so far crazy to think that that's maybe a little bit real.
So maybe they are doing that based on something
so
real.
There might be something to that.
Yeah, I kind of wanted to circle back to what you were saying about like, cultural differences and, providers in pain. Have you seen that shift over your time? Because I know you have like over 30 years experience. Have you kind of seen how that has shifted? Is there been a cultural shift in like period pain and accepting it, or?
I think that a particular problem has always been there, and I think addressed. We know more information, so every time, obviously, that we have a new finding or a new reason for this problem, then obviously, makes it more available and accessible to other people. As far as like the culture of the provider dismissing that versus not, I would say yes, because there is a new generation of providers. There is a new culture as well in training, even for the more mature providers like myself, so we have like to relearn certain things and generational. I mean, there is a difference, what my grandmother or my mother or even my siblings, and now thinking of my niece, my children, it's like there are differences into what is acceptable and what is not acceptable. So I don't think it's acceptable to say that you go to the provider and they did not gave the importance that you think it needed. But you have to be also vocal about it and not going behind on a review and say, oh, I was dismissed or that person was not empathic to me. It's to the person you have to say it. I feel that you're not contacting, you're not communicating, you're not listening to me or something to that nature. And don't be confrontational and don't have to be ashamed of that. It's just, oh, I wasn't aware of that. I'm sorry. And then you can move forward and then be more aware and helpful to that individual.
Yeah, I think that's really important to be vocal about your problems when it comes to talking to doctors, because I know a lot of people will just, if they're dismissed one time, they'll just let it go. But, if you are having that problem, it's very important to talk and speak up for yourself and advocate for yourself. So I really appreciate that. So what are some common causes of pain during menstruation?
So what happens is the pain is driven by the release of a thing called prostaglandins. And that is a hormone-like, it's a substance that your body produces, and it's kind of like a natural process. So there is a breakdown in proteins, and that is useful for healing as well for other things. So things that break down these proteins, they are all in balance. So we all have them, but when they are not in balance, then is when you have more pain. So these prostaglandins specifically are in many parts of your body, but specifically for the menstrual pain, they are in the muscle of the uterus, they are in the endometrial glands or the lining of the uterus. So when there is breakdown, when there is period, right, is breaking down all of that structure, these are released. They also help for coagulation. They help for thinning your blood. So there are a lot of functions for this. And then again, no balance, things get heavy, they get very light. And they also are the forces that create contraction. So they contract the muscles. So in people who are going to be laboring, for example, well, they need uterine contractions. So prostaglandins drive that contraction. They also help to dilate the cervix. So, I mean, there are many roles for that. So the role is the prostaglandin. That's the one that causes the pain. So to relieve the pain, you need to control the prostaglandin release. So that could be either with a medication that stops its production, controls the balance, or sort of like ameliorate kind of like, what's happening in there.
At first, when you started talking about the prostaglandin, am I saying that right?
Prostaglandin.
Prostaglandin? Okay. I wanted
Let's call it PG.
Okay. Well, I wanted to be mad at it because I'm like, this has been causing me this pain this whole time. But I'm like, it also sounds like it has some good functions too. So I'm like, I can't be so mad at it.
Yeah, we are mad at it, but I mean, for certain things, and we're happy that we have them for others.
Yeah, like it has some good functioning, but I had a lot of pain during sex. Or I just messed that one up. Pain during menstruation.
But no, I mean, even pain during sex, okay, that's a whole different physiology as well, but it does have prostaglandin derivation. It's because the PG, when you have uterine contractions, when you have an orgasm, you're having contractions, so that's breaking there. So it's creating some cramping and some pain. Maybe not all of it is derived from that, but it could be.
Okay. So Freudian slip, but also a helpful slip?
Yes.
Okay.
For everything.
Yes.
They are like the most, the substance that controls a lot of stuff in our body.
Yeah.
Those PGs.
It sounds like that. Can you share a little bit more about how it can be managed? Like you just sort of talked a little bit about it, but are there other things that we can do to try to prevent? I don't know if there's dietary issues or...
Yeah, I mean, there are things that you can try to control, to naturally control your own imbalances. I guess that would be the word to use. And then some of that could be with, for example, exercise and reduction of stress techniques, because stress also, is part of this problem. You can do some sort of like massage. You can do yoga. You can do or use the kinetic tape that are used for athletes. For muscle control and pain.
I have never heard this one.
Yeah, I haven't heard of that.
Well, have you seen athletes that have like so all of that is to control the excess contraction that you have while you're playing tennis, for example, or to prevent injuries.
Yeah.
So you can also use that, to help control some of that contractility that is associated with the menstrual
some pieces
cramping.
together for me.
Yeah.
Okay.
Because like I remember like when I would, be on my period, be in a lot of pain, you want to be comfy and cozy, but sometimes I really did need like some really tight leggings. Yeah. And it's not the exact same thing, but I kind of feel like it's making sense now because it's like
like a girdle.
Yeah, it was like I had to have something tight up top. And it was like it seemed like I really wanted to just be lazy and not have, a whole lot on, but I was like, no, I need the tight yoga pants. And turns out there's some science to that.
There is some. And acupuncture, those are all the things that you have. And there are like some pressure points that helps out to release and try to rebalance again that prostaglandin releases there. There is some herbal medications, or herbal teas. Of course, be careful where you get them from. There is a lot of Japanese and Chinese herbal medicine that is also helpful. This is all, homeopathic, complementary alternative medicine, basically. So any of that, probably in mild cases, will be very useful, very helpful. Heating pad, avoiding a lot of, some people say, don't drink too many cold things. Because the cold, again, is sort of like stimulates in a different way. Okay. Whereas the warmth or the heat, warm tea, hot tea, sort of like releases in a different way as well. So all of that is important. In terms of diet itself, like a whole list of things that people talk about, vitamins and, supplements, yes, that could be also useful. There is also the combination, because what I mentioned before about the PGs being contracting, right? A lot of people do have a GI issues, gastrointestinal problems when they have in their period, right? They have like loose stools, diarrhea, all that, nausea, vomiting. So all of that, right? So whatever you use to take to relieve that, it will probably also help for the menstrual cramping.
Okay.
Because it's all the same process. It's all the same product of the imbalance there.
Okay.
So,
yeah, because I was thinking about some of those other like symptoms aside from just the cramps. It's all still sort of connected because I used to get the worst like migraines that are really hormonal based. Like I could like
Yes.
really pinpoint it down to, okay, it's 2 days before my menstrual cycle is gonna like
Part of
hit
your
that
PMS.
part. Yep.
yeah.
And I'm like, it would struck me like I would be down for like a day.
Yeah.
And so I'm just like, are there other like symptoms that you know of or other things?
So for example, for the migraines or headaches, you take magnesium, and that helps out for that. I mean, there's like a whole list. For example, there is a micronutrients that you can do, a low-fat vegetarian diet, increase dairy intake, but those who are lactose intolerant, of course, cannot. Check on your gluten as well. Same thing with the GI issues. So vitamin E, vitamin B, there is like ginger also that helps out. Things that are soothing to your stomach, like papaya, mango, all of those things have like a lot of like powerful healing things and decreasing inflammation. So all you want to do is to decrease inflammation. And that could be with, what's the name of that thing that everybody does now, that for turmeric?
Oh, yeah.
Yeah.
Oh, yes.
Yeah, turmeric, right? So turmeric here, so that is anti-inflammatory. So an anti-inflammatory diet also helps out to reduce all of this process, because when there is inflammation, guess who's out there? Those PGs. So those PGs come out and they attack.
PGs.
Yeah, they are like, and menstrual cycle is an inflammatory process.
Yeah.
Yeah. So that's really, what it comes down to.
Are there other things to like sort of be thinking about that could, I mean, I don't want to put a whole lot out there because I know this is a big topic, but I also hear a lot of like pain associated with things like endometriosis. Are there other diagnoses or things that like we should be, tuned into and knowing like, what those things are?
Yeah, so for example, we divide the dysmenorrhea or the painful periods in two classes. So it's primary and secondary. So when you say primary, is somebody who from basically the get-go that they start having their periods, they're having pain. So this is usually something that is not associated with any other causes. So it is just steady. It happens every month. It literally starts early in the adolescence, and then sometimes with certain parts of your life cycle, for example, people who become pregnant or just as they become more adults, it tends to maybe disappear or decrease. Maybe you gain more tolerance, and then, it gets better. Sometimes it doesn't really ever go away, but it doesn't really tend to progress in intensity. Whereas the secondary dysmenorrhea will be something that at the beginning you did not have it, or maybe you had it one cycle and not 2 cycles, and then it became present to you more into the more adulthood, and then progressively worse. So those now are reasons for thinking something else is happening. So, and the reason for that is behind the theory of, again, the tissue damage that can be caused by, for example, endometriosis. It takes time for that. So for the first 3 years, maybe you're not going to have that, but maybe by the 7th year, you already do.
See. Okay.
Okay? It's depending on which theory you believe why endometriosis happened.
Okay.
So that's another topic again. But sticking to that basic principle, so things like, people who have endometriosis, another condition called adenomyosis, fibroids, polyps, had surgery, had infections like any STI that can cause pelvic inflammatory disease or PID, scar tissue. So all of those things can cause inflammation internally, and that's when, again, this pain happen. And most of the time, if it's the best time is that it's only related to menstrual cycle, but when it becomes progressively worse, because it's affecting all that pelvic area, then it's the pain is all the time. It's with sex, it's with sitting, it's with when you're doing certain exercise, when you're walking too much. So now we're thinking, okay, there is more stuff to this. And then the other reaction is tension in the pelvic floor. So you tend, it's like an injury happened. So you are apprehensive of that injury. You're tensing those muscles. So that creates a lot of irritability, a lot of injury into the area, inflammation. And then again, the pain, it's kind of like, a circle going around. Yeah. And then we have a pain memory too. So trauma is also another thing that, can cause pain, not because you have endometriosis, but because you're associating these things. And then that memory foam that we have of the pain, it's real, but it's more of a memory than an actual problem or a physical problem, I would say.
Okay. Now, is this PG also the reason why I'm bloated too?
Probably.
My personal doctor now.
It is a good question. And, and I can say, I would say yes and no. And yes, it's because, again, it's the inflammation process.
Okay.
But no, because the bloating maybe is more of like what your digestion is doing.
Okay.
And is it because the prostaglandin is not allowing the intestine to, to contract properly? Or is it because what you're eating is not really suitable for you?
Yeah.
So it's like a sensitivity to that you have as opposed to an allergy.
Okay.
So because you could be sensitive to certain things, able to eat them, and at certain times it's like, okay, I cannot have this anymore.
Yeah.
For example, I am somehow lactose intolerant, but I can eat certain kinds of cheeses. And I can eat certain kind of things that are lactose derivative, but I cannot have cow milk. But I can have something that is being cooked with the cow milk because it's processed. So the protein is broken down. It's, it's a whole different. So when I do that, it's the bloating and it's okay, my God, this is going to kill me. Right.
Yeah.
But
Well, I also find it interesting because I think, because you've said a lot and I'm like still processing, but I think you'd said something about one of the things that you might be able to eat or take is
dairy.
And so I guess if you're lactose intolerant, then you probably shouldn't, but like that's supposed to potentially sometimes help as well.
Depending on how you process it.
Yeah, definitely. It was just like fascinating to be both.
And I think that the dairy is for the calcium because it has to do with the calcium, and the contractility of the muscles, and the magnesium, all of that. That's how they work.
Okay.
So yeah.
Okay. That's helpful because I was like, oh no, if you're lactose intolerant, you get this, so you can't take dairy in order to help out.
Yeah.
So yeah. Were there other things like about pain during menstruation that we haven't hit yet that you feel like it would be helpful for us to?
Well, I mean, when you mentioned initially, when to seek help. So obviously, I mean, like in your case, for example, I mean, debilitating, right? And, and it's one of the reasons a lot, of school problems and work-related problems, obviously, because not everybody understands that it's a reality. You are completely bedridden or, you cannot function during 1 or 2 days, sometimes even more. So, yes, you don't wait until it gets to that level.
Yeah.
Hopefully to seek attention because then it will be, not very good for you.
Yeah.
So like even if you're like a 9th grader or 10th grader and you're having these issues, I mean, you have to go, And obviously understand that they could be the management, not necessarily that you want to do so natural. You might need to have some prescription medication for this.
Yeah. Well, I was just going to ask because I have, I won't name names because they would kill me, but I have someone in my life who is 15 and is in this like phase of figuring out what their like menstrual cycle is going to look like and how to manage it. And it's been, I mean, they've been blaming me a little bit because I also had, well, just jokingly, because, we're, biologically linked. So it was more a matter of like, oh, it's all your fault because I, have these terrible cramps and all this pain during menstruation because you also did, right? And so it's like, well, yeah, maybe. I don't know. But I mean,
I don't know if there's genetics into this thing, to be honest with you. I have particularly, my dad was an OBGYN as well. And every month I was like bedridden And he would say, oh, it's appendicitis. He was one of those that dismissed me. So that goes with that relationship. No,
Yeah.
just kidding. But indeed, it was very debilitating to me. So I thought I had appendicitis every single month.
Yeah.
And I was unable to I couldn't go to school, for 2 days. I was one of those patients.
Yeah.
And I was like, whatever, ninth grade, as I mentioned, eighth grade.
Yeah.
And eventually, thank God I did not need to take more medications that were at the time maybe not so great or accepted. But I did have to take anti-inflammatory medications. And I had other issues with my GI problems and stuff. So it is a lot to take. And as a young individual, you are like very frustrated and it becomes very, very difficult to deal with this. So a lot of support is important. So it's not just your gynecologist or your primary care, but also emotional support. And a mental health provider definitely, should be involved in your care because that is something that, yes, it does disrupt your life.
All right. So I have evidence that I can go back and say it's not my fault.
It is not your fault.
It's the PG.
It's the PG.
But this person in my life has gone through several different attempts to figure out how to manage the pain. And I'm not around them all the time, but I was able to do some of the things unknowingly that there's a little bit of science to them. Ginger tea and things I've learned over the course of my life. But they also have headaches similar to me. And so I was able to give these things. But they've gone through different types of hormones to figure out how to manage this. And nothing's working. And so it's really been a frustrating process for her. And so I think it's just still learning her body and figuring out. And I think they just have to find the right
but so one of the things, for example, when you have these painful periods, the goal is to start the treatment before your period starts. So basically, if you do have a scheduled, every 28 days, just to give a number, and okay, it's the 26th day, so today I'm going to start taking the medication. Assuming that this is not going to be something like a hormonal, okay? This is just anti-inflammatory medication, okay? So that's the first line. So the first line, after you have done all your, homeopathic and alternative medicine tricks in conjunction to that. So don't stop doing exercises, don't do the meditation, don't stop doing any of that if it was working somewhat. You add the anti-inflammatory medication, and that's, over the counter. Ibuprofen, naproxen, acetaminophen, which acetaminophen is not as great as a non-steroidal anti-inflammatory, but it still does work for those specifically that cannot take the NSAIDs that we called, right? So the NSAIDs work very well because they work directly into that prostaglandin balance. So those PGs can be controlled by these people. So by this medication.
those little people.
That's how I imagine things.
Yeah.
So the PGs are there, and then you have to have, the counteractors, and those will be the NSAIDs. So before they become those PGs, kind of all full blown, you got to control them before that. And the way to do that is 1 to 2 days beforehand, you start taking one dose a day, dose a day. By the time that they get to that level, it's already under control. And then you take it for the following 2-3 days, however it lasts. And if you cannot take it because your menstrual cycle is irregular, so you don't know when it's going to come, or I don't know, you were somewhere that you had no access to this, as soon as you get access to it and you are on your period, you take a loading dose. So it's a higher dose than the recommended dose for maintenance, and then you maintain it every 6 hours or 8 hours, whatever it is. Okay? So that's the first key thing, not to wait until the pain is over at the level 8. You start when your pain is level 2. Oh, I have a little cramp. Okay, well,
I'm so bad at that. I think, I can manage
it. And I know.
That's what I
know. And everybody's like, I don't like to take medications, and I respect that. Nobody, I think, likes that. But do you prefer to be on a level 8 and throwing up and being in bed, when you could have maybe for a day beforehand avoid that or reduce that? I mean,
You're
I think
you're
that would be
Yeah.
the deal there,
Yeah.
to understand that it's nothing wrong with these are not addictive medications. Sure, there are some side effects because it can affect your stomach. So you need to take it with a full stomach, with food, dairy, probably if you can. Avoid anything that irritates your stomach, like alcohol or spicy foods or things like. So, you got to be aware of these things. But it's only for 2-3 days that you're taking this, and it will be probably making your life much better. And I would say 60 to 70% of the people respond to this simple treatment. So it's not that everybody needs to go to the next level.
Yeah.
Yeah.
I think for this person, they also just have irregular periods, and so like added on top of that, like they were having like every 15 days. It was something that like was adding on top of symptoms and various different things that I think.
I'm sorry. Yeah.
Yeah. I mean, I'm hopeful that they're on various different like I think hormones to help out.
So the next thing will be that. So you can do first line would be the NSAIDs and the hormones. So the idea of the hormone is to suppress ovulation because these ovulatory cycles are the ones that are more associated with the dysmenorrhea. Okay. Although people who do not have ovulation, that don't ovulate regularly, can still have painful period, but it is because of the buildup of the endometrium. Remember that I mentioned at the beginning that estrogen keeps building up, and then it just sheds out. So imagine, right, relatively speaking, if you have 3 millimeters versus 7 millimeters, right? So when you have that to 7 millimeters that is shedding out, I mean, that's more prostaglandins that are being released. So there is more pain even though you did not ovulate. Okay, so it's all about that thickening. So the hormonal goal is to suppress ovulation, to regulate the menstrual cycle, so more predictable. And at the same time, because you are then reducing that thickness of the endometrium, okay? So you are reducing the contractibility, you're reducing the PG production, you're reducing a lot of that. So that's how that works. So that in conjunction or by itself or with the NSAIDs, it's kind of like, the happy marriage there or happy relationship. So so that's kind of like how that works. So you can use one, the other one. And then the most common hormonal that we use is the combination estrogen and progesterone, again, just to make more physiological balance, like we naturally are producing already, the estrogen and the progesterone. And then you can do progesterone only. And of course, then there are like different ways of doing that, different purposes. But the purpose per se is to thin out that endometrium, try to regulate the cycle, so reduce the blood loss that you're having and the inhibition of the ovulation. Okay. So there are like about 10 that we can talk, but we're not going to do that.
Yeah, no, I think it's helpful. I'm going to make her listen to this.
And patience. I mean, again, it's an unfortunate thing that it's a trial and error. It's individualized. So what worked for you is not going to work for me or for you. So it definitely is totally, my friend or my mom, or I saw in TikTok. Is that how it is? TikTok?
No,
in that thing. But it's okay. You saw it. That's great information. But it doesn't really apply to you, maybe.
Yeah.
Because you're a different individual.
Yeah, I think it's also helpful. I mean, this is just my own like experience with this. I take the advice and see if it works. It's like sometimes it is trial and error. And I mean, that's what I told her when I was, giving her the ginger tea or giving her the heating pad. It was like, hey, some of these things don't work for me, but like I've heard of them. Let's try them. Let's see if they help. Right? Because like what worked for me may work for you, but something else might also work for you.
Right.
So it's like, we did the, ibuprofen. That wasn't helping, to the degree that we wanted. And so let's try all these other things as well.
Yeah.
And so now maybe like what doesn't work for you right now. And so sometimes you also have to try again because your body changes.
That's true.
Like we carry different hormones all the time. And so it's like, try this again and see how this is, going to land when I'm 2 years older.
Yeah. And, in extreme cases, and, usually in very young people, that might not be the best approach, I guess. But I mean, sometimes you need to have surgery to document that there is nothing else. And again, we talked about endometriosis, not so common in the young person, but there are exceptions to everything, obviously. And there are different treatments, that are for people that have not responded to these more standardized or traditional first line and second line treatment choices, which are the medications that will place yourself like into like a menopausal state. So basically before you became to having your periods or at the end of your periods. So there are obviously serious consequences to these medications, are impacting in the long term, but they're safe to use, of course, because you want the person to be functional. And they are some therapies that can be given, medications to counteract certain of these risks that these other medications poses if we're going to be using for a longer time. But it's, again, not the first choice, like, we're going to do generation agonists and antagonists, which as they call, because they're like hypothalamic, they work at a different level in your brain, and then definitely have no estrogen in it, so it can cause other issues with bone density and then heart issues. I mean, it's a lot of things there, but it's not zero that we don't use it. It is just the last resort, I guess.
Yeah. Sounds like some additional risks and some challenges. So you want to try other things first. And we could have a whole nother podcast on menopause and perimenopause.
That was
not so much our
target audience. Our population will be selective. That would be for selective.
Personally.
Selective population.
I actually have a question for you. So can having sex during menstruation be something that alleviates pain?
Yes and no. I mean, that's kind of like, because when you have, again, it will be the contractibility, the contractions that you have, that could be like a release, like a boom release.
And PGs get released in there.
And then it's like, fine, but it could also be a trigger, to the pain. So yes and no. The answer is yes and no.
Yeah. That's, I mean, again, good information to have. I think sometimes there's some myths out there about, sometimes it can cause more pain, or it's individualized is what I'm hearing.
Very much so.
Yeah. So that's helpful. I think there's also we could probably talk a whole nother podcast about the stigma connected to sex and just period as well.
Right. But on the other hand, I mean, if some people might experience painful sex when they are on your period and not when they're not on their period. Did I say that right?
Yeah.
Yeah. So if you're not on your period, you're having sex and you don't have pain, that's fine. But when you're having your period and you have pain during that sexual act, it's probably because of that PG that is there already and then causing, right? The sex act is increasing that production of the prostaglandin.
Yeah.
Yeah.
Okay,
Well, I also can imagine the opposite too,
So-
though, because if you think about if someone has dyspareunia and maybe there's I don't know, dryness or something, I don't know, with this, lubrication that might already be there, that there's a little bit easier access.
Well, less traumatic, maybe.
Okay, less
traumatic. Yeah, that's true. But I mean, we still encourage, for people who are in the period and have sex to still protect. They can still use lubrication. I mean, there is definitely, that. There is nothing wrong, by having a sex, during your period. There is no harm done. There is, yes, a little bit more increased risk for infection. And obviously, again, we talked about cultural and religious, and other, situations where, well, that is no allowed. And that's to be respected. And communication with your partner. I mean, you have to keep a little bit higher hygiene during that time because blood is a vehicle for infection. It's a culture media.
Yeah.
So depending on the kind of activity that we are engaging in, you can have some more symptoms afterwards that are not really necessarily great, including for example, bacteria vaginosis or a yeast infection. Because you are adding to that, changes in pH that is already happening in the area that can make these organisms that are there to overgrow and take advantage of the whole thing.
Yeah.
So it's an opportunity.
Yeah. I mean, again, I think it's just helpful to be able to have those conversations with your partner or,
Absolutely.
As a conversation with yourself. Is it something that I want to do?
Yeah.
And if I do have pain during sex or pain during menstruation, do I want to try to have sex and see if that's going to be a helpful thing or cause more pain? Like that's up to you individually. Like we can't necessarily recommend or say it's no good, but I think like there's just good information to know either way. But to always be in communication first with yourself and then with others that you're potentially engaging with.
Yeah, I like that. To yourself first.
Yeah, I think sometimes we just don't
try
tune
to
into
empower
ourselves.
yourself.
Yeah, we're like, I don't know what I want, whatever you want. You know, it's like, no, let's tune in and talk to ourselves first because we're all doing it up there.
Yeah.
But I also like that you mentioned that part of this is also the mental health side of things and like the stress component. Because I do think that like that's something that, you know, as a mental health provider, I wasn't quite thinking about.
Well, I mean, when you have stress, right, your cortisol levels are elevated, and then you're having insomnia, and then you're having, you're predisposing your body for your immune system to weaken and then to create inflammation. So the inflammatory process, guess who is responsible or who's there? Those PGs.
Yeah.
So we have, again, they are like everywhere. They are like
PGs.
Those PGs are everywhere.
We're going to start a trend where it's like,
We're going to have like,
darn
we can
those
post a
PGs.
little PGs around like
PGs everywhere.
They're everywhere. They're in your body. It's like, so basically, so that's how the mechanism of that goes, probably, you know?
Yeah.
And that's how also it affects, you know, the mood, you know, right? So it's not just the estrogen and the serotonin, you know, all of the other variations and fluctuations that happens, you know, during the menstrual cycle naturally. But, you know, again, those PGs are everywhere and they're impacting everything. Everything.
Yeah.
It's like, you know,
Yeah. I just think it was really great that you mentioned that because I think sometimes I think very physiologically when it comes to like menstruation. And of course I know like stress has an impact on all of our body. You know, like I know some of those things, but it was also me just wanting to like, oh, it's all physical. So I don't need to pay attention or tune into that. So I really appreciate
no, because that affects your mental health.
You're right. You're
It affects
100%.
Everything, you know.
100%. I'm just like,
it's
mental health
energetic,
provider over
it's
here.
depressing, it's terrible. You feel not good.
Yeah, so I like that you said like really sort of considering a therapist as well as like going to a doctor because I don't think that's the first thing that I think about. Like I definitely did not recommend this to my relative who I was talking to. And I'm a therapist, right? Like so I didn't say, well, have you talked to a therapist as well?
I mean, again, there's a function for that, and I think that people unfortunately have a misconception and this stigma about mental health and therapy that it's so useful for many things, because we first feel that we can do everything on our own and we don't need any help, and that's completely not accurate. Because for whatever it is, you're not in a silo. So there's always an interaction with somebody else. And then I think that you should be able to reach out and say, okay, you know what? I'm not so sure about this. Let me seek some advice.
Yeah.
And it could be the mental health provider, you know, professional. That's great. But it could be somebody else that you trust and that you have that relationship with. I mean, some people really use people, counselors, you know. There are many venues out there available to seek that support.
Yeah.
But I would not seek the support from, or be very cautious, I should say, of those support groups that are not recognized and maybe too much of social media. Because again, I think that the negative message out there, it's so prevalent, and there is very little positive out there for that kind of like support.
Yeah.
And I think that people have to be very careful with that.
Yeah. And I think like just to clarify, I really would, as a mental health provider, recommend, you know, oh, like you have a chronic health issue or, oh, you have like a diagnosis. I would always say a mental health provider is important. I think because this is something that I have particularly dealt with. I don't know why. I think I just didn't think about it like a chronic health issue, or I didn't think.
It is.
And so for me, it wasn't something that I was like, oh, I should seek mental health. And so this is like the aha moment for me, I guess, is like one of the things.
But it's the stigma. It's the stigma, Atenel, because I mean, I think that, you know, in your generation, you know, that probably was not something that it was accepted.
Oh, for sure.
You know?
Yeah.
So, or even if it was accepted, it was looked at like, you know, oh, wow, she's just seeing a therapist.
Well, also in rural
Like
Kansas, like there wasn't a whole lot of therapists that we knew and that we like were
anywhere,
exposed to.
I think.
Yeah. So it
Yeah.
was just like, even if it was something that I was offered, like I would have to go to a bigger town.
Well,
My
just
cows aren't like certified as therapists, you
yeah,
know?
you see that my dad said to me, "Oh, go to the therapist and see how is that." No, he
Yeah.
did not. He said, "Oh, you have appendicitis."
Yeah.
That was my therapy. But I think that today we are, thank God, in a different stage, and then we have like other resources, and I think that it's our responsibility to offer it out.
I don't know,
You don't
Sage,
have to do it, but it's
are
out
we
there.
better, Sage? Like you're a different
I
generation.
think we are. I mean, I always see ads on like TikTok and everything for like BetterHelp and like getting access to therapy. And it's like, it's something that we talk a lot more about. And there's still stigma associated. I think it's going to take years before that stigma is gone. But I think we've definitely gotten
Yeah.
better. And I really like what you said about like having that like, it's almost multidisciplinary approach
Absolutely.
to caring, because pain on your period isn't just pain on your period, it's everything else. It's your mental health, it's your physical. So I really like that.
Yeah, and I'm glad that you said about your generation, because definitely it is a more acceptable way of dealing with anything. So
Yeah.
so like in the past, I could tell you, I will see a patient and will have whatever issue it was, and I said, oh well, let's just talk to a counselor or something, and it was like, well, no, like it was no. Today I sit, with some of the students, younger generation, and I said, have you thought about, talking to somebody about this? I mean, you don't have to be alone, yeah, I mean, I haven't, but yeah, I'm okay with that. Like, it's not a rejection.
Yeah.
Whereas in the past could have been a rejection.
Yeah.
Yeah.
So there's definitely a different take,
And I think also,
acceptance to it.
Yeah.
I think also I'm giving praise to your generation as well, because I think that you're also more open to talking about periods and period pain and all the things, right? And so I think it's important that we acknowledge that, we've done some good work, I think.
Well, it goes with the evolution of generation, because I mean, again, in the past it was taboo. You don't talk about even sex. You don't talk about anything. I mean, period. What is that? Just go and lie down and I know the story.
We don't want to,
So today it's accepted.
Yeah.
It's talked about in everywhere, and like this awareness is very important. And as we as advocates, I think, for our patients, should continue to do the conversation.
Yeah. Anything else that you think that would be helpful to the conversation that we haven't talked about yet?
No, I think that we touch about, how is your period, what can happen, how does it happen, some choices that you have to treat, medical management in terms of medications available. If there is anything else that you guys, think of that, we are skipping or missing, obviously,
I mean, I did just want to ask one more thing.
Sure.
So, NYU has so many different services and resources available. And what would you recommend students like turn to? Where should they go? Is there any other services that NYU has or resources? If like during this conversation, they're like, oh, that makes a lot of sense. Maybe I should reach out or...
Well, the Student Health Center have the gynecological health division, so the GYN Health, we call it. So definitely that could be a start, And there is the primary care that they also have some providers that are familiar, with dealing with these kind of problems. So I think that, you just have to find the provider that hopefully can treat you or talk to you about it. And if there's not the person that feel comfortable enough to refer you to the one that it does. But definitely there are at least 5 of us at the Student Health Center in the GYN services that, are capable of doing that. And as I mentioned, primary care too. And I think that we work closely with mental health, wellness exchange, obviously I think that, again, that's a key part to it. And some of the students actually come from that division to us or from primary care, actually. Well, I said this to my doctor and they said that I should come to GYN. I'm like, oh, okay, well, then let's start that conversation,
Yeah.
So Yeah, I think
But I
that
think, don't you have to have our insurance to be seen at, or is that not true? Like, to be seen at?
well, that's an interesting question, and the answer is no.
Okay.
So the NYU in their fees, in the tuition fee, there is a health center fee. So anybody can go to the health center. Doesn't matter if you have or don't have insurance. If you have the WellFleet insurance, that's our preferred. We are in network with them. And we might not be in network with other insurances like Blue Cross Blue Shield, for example, and Aetna. I even think Cigna, I'm not sure. Anyway, so the out-of-network situation comes when you are going to do a procedure.
Okay.
But when you are having an office visit, there is no copayment to the students, and then the insurances are billed, separately in a different situation. So the student doesn't have any responsibility there. So you can still come for your annual exam, for your problem visit. I'm not sure about the vaccinations, which ones are no charge versus the ones that are charged. And then for STI testing, it's no charge to the student regardless of insurance.
Yeah.
An STI, I mean gonorrhea, chlamydia, HIV, and syphilis. Those four specifically.
Is Pap smear covered under that as well?
Well, the Pap smear, no. The Pap smear is a part of every health insurance has the coverage for a GYN exam annually.
Okay.
And the Pap smear can be part of that coverage. So if you come with an insurance that we do not accept, you're not going to get billed by a copayment, but your test will go to the lab. And the lab will use your insurance to charge, to bill.
Okay.
So it goes from the insurance to the lab directly. We have nothing to do with that. So the Pap smear is covered. The lab will bill Blue Cross Blue Shield. Blue Cross Blue Shield pays the lab back. And then whatever arrangement they have, that's between them. And then if there is an additional copayment because that's your contract, that's another story. Right. So we don't have control over that.
Well, I was just thinking maybe if someone had pain during menstruation, a Pap smear might be used.
It doesn't have to be because,
okay.
If you're 19 years old, you don't need one. So we don't do it. And if you had one last year, you're 25, you don't need it either.
Yeah.
So no, it's not going to be part of the evaluation. Okay. Actually, now that you mentioned that, yes, I want to talk about this. We have time.
Yeah.
So when you go to the doctor or provider, to get the evaluation for painful periods, you remember that you do not have to have a pelvic exam necessarily. Okay. So for people who had never had anything introduced vaginally, have a fear of a pelvic exam, they don't need to have that exam. Okay. The exam is for someone who we are thinking that has a secondary dysmenorrhea. So we're looking for causes.
Okay.
That had probably been sexually active vaginally because we're looking for probably STDs and PID type of scenario for individuals who, despite of everything that we have done, we cannot find a reason, and then we might need to do a pelvic exam. So the pelvic exam is not necessarily mandatory on that at least initial visit. So you can come, you can talk. We can disclose, what is the alternatives that you might have for treatment. Do you need to have blood work? Maybe not. Do you need to have a pelvic ultrasound? Probably not. Okay, because primary dysmenorrhea doesn't have a cost, right?
Yeah.
So those PGs are not going to be showing in any blood work or in any ultrasound.
Yeah, that makes sense.
Right? So think about that because, again, that's another thing. People say, I need this test, I need that test, I want this. Sure, you want all of that, but is it really necessary? Is it going to be covered by your health insurance?
Yeah.
Yeah, I think it's really important about the pelvic exam because a lot of people will turn away from going to see a doctor in fear of having one. And so I think it's really important that you don't have to have one the first time.
That's right.
Yeah.
And even if you are due for a GYN exam and a pelvic exam, a Pap smear, you don't have to have that visit either. It's all about when do you need it that is necessary.
Yeah.
So it could be next week instead of today.
Tune into our episode where you talk more about that in season 2. I really appreciate this conversation. I really connected it to so many things in my life.
Glad that it helped.
So I appreciate that. I also wanted to name as an alternative. Again, I think the Student Health Center, it's great. And it's good to know that like doesn't matter your insurance, that like a lot of the procedures or a lot of the visits are covered. But there's also an organization that I've worked with in the past called the Purple Clinic. And they are, I mean, I could think more specifically because I work with people who experience sexual assault. There are a bunch of folks who have a lot of history of working with people who have experienced sexual assault, and they will do GYN visits, but they also have like good referrals for like dentists and all these other like providers that are also really trained in trauma-informed care. So I know that sometimes like it can be hard to find people off campus providers. I know that our Student Health Center does a really good job at the referrals as well. So I think that's something to highlight too.
Thank you for that. Yeah.
So thanks so much for joining us, and tune in for more Good Sex at NYU.
Well, thank you for having me, and it's been a pleasure.
All right. Thank you.
Yes, thank you.
Questions or feedback? Email us at goodsex.podcast@nyu.edu. We typically respond within 3 to 4 business days. We know we can't cover everything in one episode, so if we missed something, got something wrong, or something didn't sit right with you, we'd love to hear from you. Check out our show notes for links to books, organizations, or other resources. If you have questions about your sexual health and you're an NYU student, you can reach out to our sexpert at sexpert@nyu.edu or book an appointment through the Student Health Center portal. If you're facing an urgent mental health or safety concern, NYU's Confidential Wellness Exchange is available 24/7 at 212-443-9999 via their app, or wellness.exchange@nyu.edu. For non-NYU listeners, you could call the National Sexual Assault Hotline at 1-800-656-4673 or the National Domestic Violence Hotline at 1-800-799-7233. Tune in next time, and don't forget to subscribe for more Good Sex at NYU.